Thank you, sir, for your kind words of introduction. I have always felt extreme bliss when I come into this institute. I have told Dr. Chalam that I am honored to be here, lecturing in this such a pious place. Actually, I want to start off, before I start my lecture, I want to give you a statement which Japanese have made. They say that when a person passes away, there are two deaths that a person has. One is when he passes away and physically no more. Second time is when people stop talking about him. But now you know why Satya Sai is immortal and eternal. Because I don't think any time we will ever stop talking about him. And it's always a pleasure to listen to Dr. Chalam talking about his institute. So we are all honored and blessed to be here. And with that, I will take on to my topic of regional anesthesia in cardiac surgery. The very concept, hypothesis of regional anesthesia in cardiac surgery is controversial because no cardiac surgery happens without anticoagulation with heparin. So you are taught, and the American Society of Regional Anesthesia has given guidelines that the combination of anticoagulation and neuroaxial blocks or even non-neuroaxial blocks are controversial. So with this controversy in background, I am starting the lecture. I think Dr. Chalam has chosen me to speak on this because we have done a large number of epidurals, probably the largest in the world in cardiac surgical patients. I will share some of my thoughts with you. So what are the regional blocks that we are looking at? Epidural, total spinal, spinal, paravertebral block, serratus anterior plane block, SAP block, and the intercostal nerve blocks. So these are some of the blocks which are available for cardiac surgery. Of course, I am not talking about the percutaneous infusion of local anesthetics, which is coming up in a big way currently. A thoracic epidural, contrary to popular belief, is not difficult. This is the cervical and thoracic vertebral space. This is the mid-thorax from C7, T7 downwards, and of course is lumbar. With my experience, I can tell those who want to practice thoracic epidural, it's great fun doing it, and you need to be highly concentrated, and it's no joke in that because the subdural puncture could damage the cord itself. Here, many people at lumbar have a habit of doing subarachnoid block. You pass the spinal needle right up to the posterior surface of the vertebral body, where you are going across the subarachnoid space, which is, of course, to be shunned. That can never be done in thoracic epidural. So you ought to be careful. And I can also say that we, in our about 3,000 cases of epidurals, we have had 3 or 4 dural taps, and they have not caused great deal of any problem. That does not encourage you to try that. If it happens accidentally, please quickly take it out and don't experiment with that same space again. So the thoracic and cervical are quite easy, and it becomes more oblique as you go down, and you have to be closest to the incision. You can do various non-cardiac surgeries as well. I have done thyroids, I have done carotid endarterectomies, I have done breasts. Many times some of the wound debridements in patients who are not good candidates for GA, it can be used. So the trick is to use the epidural closest to the incision. If you are planning to do a cardiac surgery under epidural or as a supplement with general anesthesia, anywhere between C7 and T2 is quite all right. Even T3, T4 is okay, but as you go down, it gets technically difficult. I am not going to tell you what epidural does to the pain. We have done awake heart surgeries without general anesthesia. That suffices to say pain relief is excellent. But epidural is one of the few anesthetic techniques which has been investigated for the non-anesthetic properties. There are people pro-epidural and against epidural. There are very few in between. I don't mind epidural, I will try. That kind of people are not there. People are who are pro, who say you are unnecessarily casting aspersions on a very good technique. Those who are against epidural say that you cannot afford to have a paraplegic or quadriplegic patient after a successful cardiac surgery. Anesthesia is not therapeutic. It is only supportive. So you can't afford to have too many complications because of anesthesia itself, because the surgeons are there to cause the complications and they can justify it. So we should not join them in causing complications. And suppose a patient after a mitral valve surgery bleeds, that is accepted. But after mitral valve surgery becomes quadriplegic, is not accepted. So this is a huge right and left wing which is working. And also there is a different story why epidural has been kind of in literature snubbed. For paucity of time, those who are interested, I can share with you over tea. So it also has action on various systems. As you know, neuraxial block affects all the nervous system, not just the spinal cord or the intercostal nerves. It has action on the brain, it has action on the brain stem and spinal cord, of course. So it has cardiovascular action, central nervous system, neurohumoral system, splanchnic circulation, coagulation, and stress. So these have been investigated thoroughly. And I will go one by one. Cardiovascular, there is a reduction of heart rate. And the typical thing about a successful epidural is when the surgeon makes an incision, the heart rate does not even change by 1. That is, epidural is acting. If it is not acting, like usual, it might increase. That is the time when you put your sword down and say, my epidural is not acting. You will see people add some bicarbonate, give some xylocaine, give some fentanyl. That is totally intravenous anesthesia. That you should not practice when you're practicing epidural. Epidural, it works or it doesn't work. So we have to be ready for a blind technique not working. And it blocks parasympathetic and sympathetic nervous system in that order. It is important, all postgraduates in anesthesia think sympathetic block is the most important block. We did some very primitive research about this and shown that parasympathetic gets blocked first and then the sympathetic gets blocked next. You will, those of you pundits there about autonomic nervous system will ask me next, why do the patients not get bronchospasm if parasympathetic is blocked first? It is because the bronchospasm does not occur. That is clinically known. We all have experienced it. Because we don't know about autonomic nervous system enough. There's a topic which is very least investigated. A lot of scope for research is there in that. And response of sympathetic amines is preserved. Typically, the heart behaves like a transplanted heart. It is denervated. But still the amines work because probably, even there we don't know much, probably there are intramyocardial alpha and alpha receptors are there which respond to these medicines. Not alpha, beta receptors. And we shown decreased incidence of atrial fibrillation if you use it in conjunction with general anesthesia or alone. And the heart behaved, like I said, a transplanted heart. This is the ANSI scope which we used many years ago. And I'm sure Professor PMC has also used this. And in this, you see, this is the parasympathetic, this is the sympathetic. Normally, it will be going around here. As soon as we give an epidural block, it completely parasympathetic is blocked and the curve moves here. After about 10 minutes, the curve moves back in the center where the sympathetic and parasympathetic balance is restored. Now this equipment is available in this avatar and we are continuing to use it. And it's a very, very good equipment. Anybody interested in research on this topic, please contact me. I can get you a free equipment to research on and use clinically. And what are the other effects? The reduced ST segment changes, and theoretically, it is said that you can use epidural to patient to alleviate the myocardial infarction pain, reduce the size of infarction, reduce the reperfusion injuries, etc. But for obvious reasons, we can't use it in myocardial infarction. And there is an improved endocardial flow and a reduced infarct size for coronary occlusion, reduced incidence of malignant arrhythmia. I must tell you, we have used in a patient who had unstoppable ventricular tachycardia, which he was having no pulse at the time, and he was thrombolized, and nothing worked in him. Even sotalol did not work. The cardiologist asked me to put an epidural. Moment we put an epidural, the monitor became like a simulator, and it worked beautifully in that patient. So it works very well in arrhythmias. It improved myocardial pH. Secondary to suppression of ischemia and induced stimulation also was lesser. What about the brain? There is a deafferentiation. When you give an epidural, patient essentially feels only face above. Even the neck is blocked in a thoracic epidural. That's how you can do a thyroid, carotid endarterectomy, etc. The patient becomes drowsy because the inputs are less. You know, some of you sitting here, the inputs from this side, when the speaker's inputs are less, you will close your eyes and sleep. Similarly, after an epidural, when the input is less, the brain thinks that there is no stimulus coming, you are not feeling anything, there is nothing touching you, so you fall asleep. What is the lesson that we have to learn? When you give a thoracic epidural, be very careful with your opioids and sedatives. Even 0.5 milligrams of midazolam, patient will start snoring. We did the Ramson sedation score in just epidural patients, and we put the BIS monitoring in them. So it produces tremendous sedation. And also it reduces the incidence of neuropsychological disturbance. My good friend Colin Royce from Sydney has done a wonderful study, and also it came in big time in the press also. Patients who received epidural were analyzed 6 months later after cardiac surgery. The neuropsychological changes are much, much less. So this works there. And there is in the event of a dural tap, there is very low incidence of postspinal headache, possibly because the subarachnoid pressure there is less, the leak is much less, compared in contrast to the lumbar area where the pressure is high. What about the neurohumoral system? There is reduced cortisol and catecholamine studies. There are n number of studies about that. Lower catecholamine and cortisol levels following sternotomy, and glucose metabolism is facilitated, so the requirement of insulin comes down. What about the splanchnic system? You know, those who practice epidural in general surgery, you see the gut becomes like a thin worm because of the contraction, hypermotility of the gut. So gut moves, and rarely ever you will find an epidural patient have postoperative nausea, vomiting, and he is ready to eat and drink. They say, first thing when you say, how are you? They say, I want water, I want to eat. So it's very common observation. And there is a better liver perfusion and improved gastric circulation, improved tissue oxygenation. So overall, we did a simple study where we checked the mixed venous oxygenation of patients who did epidural, no epidural, on pump. We found that the mixed venous oxygenation was always normal, and the expired venous oxygen was always higher, that suggesting that the oxygen supply to the tissue was more and the oxygen extraction was better in epidural. Surprisingly, epidural decreases the blood loss and it improves coagulation. It has got decreased transfusion requirement and decreased fibrinogen levels, decreased incidence of thromboembolism in patients with dilated cardiomyopathy. So this is a beneficial effect. And the stress, it also reduces the trauma-induced stress, and thoracic epidural, it reduces the inflammatory immune suppressing mediators. It improves the recovery and reduces the morbidity due to post-traumatic stress. Yeah, in what ways can you use? You can use GA plus epidural, awake, or post-operative epidural with local anesthetic and opioid for pain relief alone. Benefits are, of course, fast tracking, short duration of length of stay in the ICU and hospital, superlative pain relief, reduced AF, lower stress. And we did this publication in Annals of Cardiac Anesthesia. This is how we started, mid-cap first, and then we did the awake heart surgery. Then we also did on-pump surgeries with epidural. And epidural hematoma, there were only 2 cases described in the literature so far, one from Pune and another one from the US. There are many epidural hematomas in cardiac surgery where epidural was not administered. Okay? Sternotomy itself, thoracotomy itself, if the surgeon is gung-ho about thoracotomy, especially posteriorly, he puts a mop and pushes it, it can reach the epidural space and can have hematoma. So unfortunately, both the epidurals on one side and the hematomas on the other side go unreported. Nobody wants to say, I had an epidural hematoma, because the complication, nobody likes it. This is a review that I wrote in the Journal of Thoracic Cardiovascular Anesthesia about use of thoracic epidural anesthesia. And then Dr. Kaplan asked me to write this review where I wrote about future of awake heart surgery. This is probably the saddest moment in anesthesia according to me, because in 2003 awake heart surgery was popular, and in 2013 I was writing the future. Such a short duration of journey that epidural enjoyed. Unfortunate, but mark my words, it will make a comeback. Epidural is going not because anesthesiologists have failed, it is because cardiologists have robust evidence in giving anticoagulant, antiplatelet medication in every ischemic heart disease patient, because for a person with hammer in the hand, everything looks like a nail. So they have a balloon, so every block can be opened. So I don't want to talk more about that, but I concluded in that lecture that unless shorter acting antiplatelet medication, which could be titrated, whose action could be assessed, arrive in the market, carrying out any neuraxial block and technique dependent on their use would go the dinosaur way. Next, of course, you can try spinal opioids. It can be an adjunct to general anesthesia. Pain relief is about 36 hours. Spinal morphine works beautifully, 100 mics of spinal morphine. After induction, turn the patient, do a spinal and just give morphine. 50 to 100 works well, and less chances of epidural hematoma. And our own Chirojit Mukherjee from Leipzig has reported in Annals of Cardiac Anesthesia saying that it is superior to other modes of block. When I was doing a research for this topic, I came across this paper, Total Spinal Anesthesia for Cardiac Surgery, that is make a difference. What they do is, it's not a conventional total spinal where you inject a large quantity of local anesthetic in the epidural subarachnoid space, wherever. No. What they did is they gave a spinal anesthesia and gave a steep head low and got the spinal to work till T1, T2. And they did the cardiac surgery. They intubated the patient and did the cardiac surgery. They showed that it was good, beneficial. I gave a lecture in Aurangabad a few days ago on future of cardiac anesthesia. They wanted me to speak on that. At that time, when you talk about future, you can talk any nonsense. If you are lucky, it will come true. And they say, oh, what a genius, he had such a forethought. So I said, in future, total spinal anesthesia can become the anesthetic of choice. You can operate anything from brain to the toe. So it's such a wonderful technique. So low cost, no damage to the atmosphere, no halothane sevoflurane required, nothing. Just seriously think about it. Because if you do carefully produce the total spinal, you might not have hemodynamic disturbance. Like I told you, the heart still mercifully responds to the inotropes. Of course, paravertebral block is a very simple block to do. It can have adverse effects, so be careful. It's not possible to carry out in midline surgery. This is what I wrote. But Dr. Pankaj, when I was having breakfast, your neurosurgeon was telling me that a surgeon from UK anesthesiology from UK came here, would anesthetize babies, turn them over and give a paravertebral block, and it would produce analgesia full. It was news to me. I should thank Dr. Pankaj for telling me this news. Maybe we should try in adults some paravertebral block. It is suitable, excellent for thoracotomy. Surgeries you do by thoracotomy, it's excellent. Mid-cap, it works beautifully. Ultrasound helps. Why is ultrasound necessary? Because when you go, I will show you, I don't know if I have. You know, it's very simple. You feel the transverse process, you walk across the transverse process, then it dips. Then behind the transverse process is the paravertebral space. But in front of that is the pleura. Okay? So a man with a needle is as dangerous as James Bond, ready to shoot. Because if the needle doesn't know what is pleura, unfortunately, we are supposed to know. That is where the ultrasound helps. We can insert a catheter, and total spinal, intrathecal deposition, hematoma, epidural hematoma, all can occur. The surgeon can do it on the table. They can insert a catheter in the paravertebral space. It works very well. This is the ultrasound. You see, this is the transverse process. You walk across the transverse process, go posterior. This is the silver lining that you see is the pleura. How do you identify? Like waves, it comes and goes. Very simple. Just put the probe there and wait for a while. You will see the movement. That is, if you still are not convinced, ask the patient to cough. That pleura will come and hit your probe. And the SAP block is something which is new. After ultrasound has come, people are exploring everywhere whether they can put a needle and give local anesthetic. Not a bad idea. But this is a SAP block that we did. I hope the This is not working. This is a video which without the video you will not be able to understand. Dark shadow that you see is the rib. On the fifth or the fourth rib, you deposit the drug which is posterior to the serratus anterior. And you can give about 20 to 25 ml of local anesthetic. This is a patient who was hardly able to breathe after a mid-cap. And after we gave the blocks, he got so excited, he wanted to know what Modi was saying in the newspaper. You can also insert a catheter in this. So, what is the summary? Regional anesthesia blocks aided by ultrasound is useful. I think wherever, even epidurals, you can calculate the depth of the space. If the epidural is at 7 centimeter, please do not insert the full needle because you are likely to encounter the holy fluid coming from the subarachnoid space. Beware of antiplatelet medication. I have attended some lectures where some anesthesiologists very cowboyishly said, I have given so many epidural blocks in patients with antiplatelet medication, nothing happens. Wrong. If it can happen, it will happen. And if you are unlucky, it will happen to you. So be careful with this. Future is not very bright considering the legal scenario, especially. In fact, one of the papers on future of anesthesia says anesthetic complications will not be tolerated. Anesthesia will be expected to be foolproof. Considering that, any blind technique, whether it is epidural or a regional block, will fall into some kind of a pressure area. Thank you very much.
Sir, thank you for a very clear and crisp presentation. Regarding anticoagulants, antiplatelets, what you told, suppose if you are putting electively for these patients epidural, how long do we wait?
It is recommended that we wait about 8 to 10 days. But most surgeons accept 7 days. But if you are a little worried, and if you are a novice epiduralist, better not to do, wait for 10 days, otherwise a week. We don't mind a week because you guys operate on coronaries after a week, neurosurgeons operate on the brain after a week, so we think we are okay. But the problem that we face is, when you have a hemorrhage, you can see and you can suck it out. When epidural hematoma occurs, even a small quantity like 10 ml can produce a neural injury.
And I think epidural is meant only for acyanotic cardiac disease.
Cyanotics, yeah, they have as such
bleeding discrepancies will be there.
They have coagulation abnormalities. Yes, it is. I have never done. I have done some pediatric, but they're all acyanotic, and I am not like Srinivas who see adult gooch patients. No, we don't have. I don't have experience actually.
Okay. Thank you, sir. Any questions can be asked?
Yes, Srinivas.
Above 5 kilos. ASD patients, we tried few ASD patients and extubated on table.
Okay.
And one tetralogy was done by my colleague, not myself.
No, but Srinivas, is your experience the same thing what Dr. Pankaj was saying? One epidural. See, conventionally, there is a paper from Iran. They have put 8 paravertebral blocks on both sides for a CABG.
Yeah, we give bilateral block under ultrasound guidance.
Okay.
We tried only few cases, not as many, not a very large.
Single blocks and bilaterally?
Bilateral, single blocks.
It works full length?
It works, yeah, above 5 kilo, and we could extubate ASDs, 3 or 4 ASDs on table, and within 2 hours we could extubate the VACs.
Super.
We tried in simple acyanotic patients.
Yeah.
Only one tetralogy was.
Actually, the guru of pediatric epidural is in India, and he is Vipul Sharma. He is in the armed forces. And anybody wanting to see, learn, understand, such a nice human being, he will give you a full lecture and show you how he has never experienced death due to pulmonary hypertensive crisis in his practice for many years. So I'm sure you agree that Vipul has a large experience. Yeah. Yes, he is published. Because I had a fight with him. If you don't publish your data, I won't speak to you. Because it's a very important data. Thank you, sir.
Okay, thank you, Dr. Murali Chakravarti.
Yes. It is on, Naman.
Yeah, actually we have tried after coming out by part, bypass just before shifting the patients on table, like after protamine over components are given in cyanotic patients. So far 50, 60 patients we did, but about 5 to 10 kg, not below that. But like, I just talked to Dr. Vipul. I think in USA, the morphine, bottle morphine and the intrathecal morphine, they are much practiced in the epidural in the pediatrics and cyanotic, because bottle epidural is still better for the pediatric age group of patients, particularly morphine. So they give just one shot of the pediatric epidural, the bottle epidural morphine, and then they forget it. So I think if we are talking about the cyanotic patients and in the younger crowd, I think the caudal epidural should be the
Yes, I think I missed that out. Yeah, you're right. Yeah, I have heard, seen cardiac anesthetists who practice routine. It's so easy. You just don't need any big needle or any ultrasound. So you can just insert it. Yes, I agree with you. I'm sorry I missed that.